First of all, you have to distinguish between sex differences and gender differences. Just as a reminder, the term sex refers to biological differences between man and woman, while gender is a social construct and refers to social characteristics of man and woman, behavior, attitudes, roles and relation. And it's well known that both of them impact health and disease throughout the lifespan. And first of all, it starts with the epidemiology. The epidemiology of gastrointestinal cancers is influenced by the patient's sex. For example, lower esophageal adenocarcinoma in white persons is a disease which characteristically affects men for reasons which, there are some explanations. For example, we know that the body composition with visceral fat is a risk factor, as well as reflux disease, but it's not finally the risk factors which explain why men have, which explain sufficiently why men have much more often lower esophageal adenocarcinoma. This is one of the examples for a sexual dimorphism in cancer. Other ways, for example, in gastric cancer, you have in women much more often, we have more often corpus adenocarcinoma, which is typically signet cell or poorly differentiated histology and occurs in young women. And has a particular dismal prognosis. This is as well a subtype which occurs more often in women. Furthermore, and in colorectal cancer, you have more often microsatellite instable tumors in women, which you have as well in gastric cancer, more often in women. Furthermore, in colorectal cancer, you have significantly more often right-sided tumors in women, while you have more often rectal cancers in men. So these are different ways how the location and the biology of the disease can be influenced by the patient's sex, biological sex. Certainly, in addition, the behavior plays a role. For example, smoking and drinking impact the risk for esophageal squamous cell cancer, and in many countries, more often men do much more often smoke and drink. So this is why they have more often esophageal squamous cell cancers. So these are examples for the impact of sex and gender on the biology of gastrointestinal cancers. Furthermore, you have impacts on the treatment outcomes. The classic chemotherapy, the mainstay of treatment for the majority of gastrointestinal cancers is 5-FU, and 5-FU is a classical example of a drug which has a significantly higher clearance of about 20% in men. This is why the men have lower plasma levels than women, but this is known since more than 20 years. And furthermore, we know that, and this is probably the reason why women have significantly higher toxicity, and this significantly higher toxicity reflects it concerns not only, for example, nausea and vomiting, but as well hematological toxicities, neutropenia, which is objectively measurable. And I had the pleasure to work with the colleagues from the Accent database at Mayo, where we analyzed about 30,000 patients receiving adjuvant chemotherapy. This is now, the manuscript is available in JNCI, and there was a very nice editorial has been written, Make 5-FU Sexy Again, because the author of this editorial understand that 5-FU is a good case and an example for a drug where these sex differences in clearance in the drug clearance need consideration in the dose. The problem is how we dose chemotherapy at the moment is according to body surface area, and the body surface area does not take into account the differences in fat-free body mass between men and women. This is probably not the good way to dose 5-FU, and host factors in general are are usually not considered in chemotherapy dosing, and I think this is something we should improve in the future. So the toxicity is different. Furthermore, the efficacy in colorectal cancer, we did another analysis of the ARCAD database. We did not find any differences in efficacy. For me, that was surprising, because if you have a higher toxicity you have higher drug levels, I would expect a higher efficacy, but this was not the case. Nearly in all subgroup analyses, there were no arguments for a higher efficacy of 5-FU-based chemotherapy in women. So that is one option. Another interesting option is, another interesting example is the so-called BILCAP trial of adjuvant capecitabine in resected biliary cancer, where if you look at the subgroup analysis of men and women, the hazard ratio of the benefit, of the treatment benefit of adjuvant capecitabine is much greater in men than it is in women, which is probably due to the better prognosis of the untreated disease in women as compared to men. So this is something, and we know that the resorption, the pharmacokinetic, does not explain this difference. Probably it's a difference in tumor biology which is responsible for these differences in treatment outcome. Certainly this may as well be a difference in just a statistical error due to a subgroup analysis, but we can't be sure, and I think we need further data to find out how big is really the benefit of adjuvant capecitabine in women with biliary cancer.